So, Dr. Shah, is SCAT actually going up, or is it just being recognized more?
I suspect that it's we're doing a much better job now for diagnosis, and actually, when we look back, we certainly miss a lot. And when we look at the incidence, yes, overall you're seeing an increase, but I suspect that it's just we're a lot better nowadays, and sometimes we might be actually overcalling. So
Yeah.
there's a yeah.
Would there be a reason it would be going up, meaning women are having pregnancy later, more women are using newer contraceptive therapy? What are your thoughts?
Yeah, I think it's hard to know. I mean, and that's one of the unknowns about SCAT is the true prevalence, right? Because we're still missing some cases. And, we're identifying what some of these risk factors are. Is the incidence of FMD greater now because of perhaps hormonal use and environmental exposure as well?
Yeah.
I don't think we really know the answer. Although when we look at the cases, I do suspect that it's just that we're doing a much better job now in terms of knowledge translation, educating all the angiographers. We're much better picking it up. And even before patients come to the cath lab, now the emerge docs and our general cardiologists are already suspecting SCAT to begin with in the right patient population.
Correct. Very exciting. Dr. Shah had a comment.
Yeah, no, like as Dr. Saul already pointed out, that we are doing a better job picking it up, and oftentimes if you do have an NSTEMI or whatever, an MI with non-obstructive coronary disease or something that just doesn't, or what appears to be angiographically normal coronaries on angiography, during a busy day, you may miss it in the small branches. It's worthwhile to go back to your angiographer, your interventionalist, and review the films again in the light of day with them, because they may have missed it. I've missed it, and the next day I'm looking at it and I'm like, you know what? There's something actually in that small diag or OM. So I highly encourage interactions in the cath lab between you and the interventionalist to review these films a little bit more closely and put it in the context of the clinical scenario, because you may pick it up.
Yeah, and looking at your left ventricular angiogram, if you see the wall motion abnormality, you should go back and look for it. And that's, previous comments in the previous session is, should a patient leave the cath lab not having a diagnosis, right? If you don't see it in the cath lab, I think the next step is, as Harmony mentioned, we will be doing MRI as other reasons to look for a minoka.
Exactly.
Excellent.
Excellent.
The cause of minoka, yeah.
A question from Dr. Quesada.
Yes, a fantastic session. I had a question regarding SCAT, and in particular, the etiology of that 30% of chest pain years out, and comments on microvascular dysfunction, and also the safety of functional angiography for those patients with SCAT with ongoing chest pain.
Yeah, that's a great question. We did do a study called Safer SCAT, where a lot of patients with ongoing chest pain, we have done microvascular function testing, and a significant majority of these patients, it's a small study, but they did have abnormal CFR and IMR as well. And we kind of suspect a lot of these patients have underlying coronary FMD, and that perhaps might be the etiology for these microvascular dysfunction. But as to the cause of long-standing atypical chest pains, years post-SCAT, it's very common. The true etiology, it may be related to microvascular dysfunction, but I don't think we truly understand it.
Yeah, I always worry about that distal embolization that may or may not have occurred, and just some capillary obliteration. A question from the audience.
It's so great to see so many great minds in one room. A question to Harmony. What is a safe time frame to do functional testing in patients with minoka where we highly suspect spasm as an etiology?
Thank you, Dr. Taleva. This is a great question. I used to think that this was not safe to do acutely. I mean, it makes sense to me that this would not be safe to do acutely. But there are a couple of studies in which these were done acutely, and it seems to be safe. I can't say that I am recommending this acutely right now in our lab, but I'm usually bringing people back if they have persistent chest pain. And that seems to be the impetus for redoing angiography, and that usually winds up being somewhere around a month. we haven't had any complications, but then we haven't had any complications in the series with acute provocative testing as well. I wonder if anybody else on the panel, Dr. Bairey Merz, has a comment on that.
Yeah, the Casper trial in Germany included almost 40% were acute coronary syndromes, and they described a very high prevalence of microvascular spasm, much higher than we've ever seen, and they had a higher complication rate. So I think, and that's one study, but we need to be mindful of how much we really need to know in the heat of battle, and we're trying to be convenient. You can imagine, and I think that's what you meant, Dr. Reynolds, they're hot. Everything is bad in an ACS, and so you may have a false positive prevalence of spasm that actually is not true in a more stable situation. Yeah.
Yeah, that's interesting. I hadn't so much thought about it being false positive, but I absolutely see your point that this is a time where the coronaries are very reactive and it may not persist over time.
Exactly, and then you misattribute persistent symptoms or evidence of ischemia. That would be my concern. We'd have to do more research, of course.
In thinking about microvascular testing, this has been a defect of our ability to discern whether microvascular coronary disease is a contributing factor to minoka, because by the time we've diagnosed the patient with minoka, they have an MI, they have microvascular compression from their myocardial edema, and they may very well be abnormal, but we don't know why they're abnormal, and we don't have a window into what happened before the infarct. So I think that's a very important area of investigation as well, is to try and bring people back further down the line when you no longer think that they have myocardial edema and see if they have microvascular disease. We still won't know if they had it beforehand, but at least it would be something.
Yeah. Dr. Gulati, what is the intervention in NACRUM? And sidebar, the observational intertox study does suggest that ACE inhibitors are associated with a reduced recurrence. What are your thoughts about both of those?
So the ACE inhibitor issue is being addressed by that one study that's ongoing. I think that they're
The NACRUM.
Yes, they're looking at that. Sorry, what was the first question again?
The observational data in the large intertoc does suggest that an ACE prescription is associated with a reduced recurrence. Obviously, observational data can be confounded. Is there pathophysiologic reasons to think that could be effective?
Yeah, I don't know if I know the answer to that.
Yeah.
So I think there's a lot of hypothesizing. That's what after reading so many of these well-written reviews, and I'd encourage you all to read both the most recent one from this year in European Heart Journal and the one that just came out a couple days ago in Circulation. It seems like we don't have a good grasp on why, and we're not even predicting based on what we're seeing who's going to have recurrence or who's going to have adverse long-term outcomes, aside from the things that have gone into those risk scores. That's right now the only answers.
So we have, I think, 4 Takotsubo abstracts for deeper phenotyping and for just incidence, but also recurrence. And the proteomic analysis we did with Dr. Jennifer Van Eyck, and these are posters on Sunday and Monday, if you're interested. They look more like a cardiomyopathy cohort in terms of the proteome signaling. Work unfolding, of course, but I think that's what you meant, Dr. Gulati. We need to be able to do a better job of who's going to be persistently sick and who's just going to have this one episode and not recur. Yeah. Dr. Shah, so the VSD post-MI, I think it was post-MI, but you're going to teach me because I'm not interventional anymore. It is more common in women, but is that because they delay, or do you think it's biology, it's sex differences?
So I don't know of any biological reason that there would be a difference, but I'm not sure. I think we just don't know the answer to that. It is interesting that the handful that I've had in my career were all women. I take it back. There may have been one man somewhere in the middle of that, but for the most part, they were women, and I do wonder if it has something to do with the delayed in presentation. It's the rupture that's just so dramatic in terms of symptoms that they definitely come in at that point.
Yeah, And then a follow-up question. Weight-based heparin came out maybe 25 years ago as part of the antidote to women's increased vascular complications, which were mostly bleeding as opposed to clotting. But what about the newer agents? Do we feel like we have female dosing for all of our super anticoagulants?
Yeah, we don't have sex based differences in dosing for our anticoagulants. For me, although the first two cases I did show was femoral access, I'm a big proponent of radial access in the lab, and we still are 95 to 98% radial access to try to reduce those complications, so that we can use the more potent agents like prasugrel, ticagrelor, cangrelor when we need to.
Mm-hmm. And do you think that that would be important? Isn't there a persistent increased risk of bleeding in women compared to men? I could be wrong, but yeah. And so shouldn't those drugs be tested for sex differences in pharmacology?
Yeah, our data is only as good as the patients that are represented in the trials. So we've come back full circle to the first discussion on representation in clinical trials.
Yeah, exactly. Any other questions from the audience or the panelists that you would like to ask your colleagues? Okay. All right, excellent. Dr. Vogel, come up and help me close. At least that's what Dr. Mehran had asked us to do. I'll sit here. Why don't you close? Because this has been a lovely, lovely afternoon.
Thank you so much. So, yeah, thank you to everyone, to the presenters, to all the attendees. We are really grateful that you could all attend. We hope this was only the beginning. So many great presentations, so much to do also. We got a great outline, I think, of all the to-dos that we should target for the next. I mean, now is the year of awareness, but then also the action should follow. And hopefully we will meet again on those more symposia that we will have for the educational series, but also in collaborations and initiatives for this cause. Thank you so much.
Thank you so much. And